And now it gives me immense pleasure that she has been matured and she has been turned to a wonderful doctor and a wonderful woman who is passionate to everyone. And she did her schooling in Calcutta Girls School, Kolkata. Then she did her MSc in integrated biotech BTech, MTech, MSc in St. Xavier's College. That is MTech in biotechnology. And all along, she was a KVPOA scholar. And I know Nandini, she was so dedicated that she would be going to for practicing medicine for people, that after completing her MTech in biotechnology, she started studying medicine in US. And now she's a full doctor. And in this COVID-19 warrior, she is a frontline warrior in this battlefield. She is the one who has served for people, for many persons, mothers, children, and all. So now we are all devastated with the pandemic, and also in Calcutta, you know that the cyclone has also devastated us. So in
Mm-hmm.
this condition, but you know that whenever we requested our, we informed our scholars and Biganikona, then and also our staffs are here. So they were very much enthusiastic to listen to Dr. Nandini Chattopadhyay. And so it's really nice that Nandini, in spite of all her busy schedule and very active program, she has given her time to interact with us. So Nandini, it's a very good moment and we all welcome you. And whenever next time you will be in Calcutta, we will felicitate you in our office. So today, let us listen to Dr. Nandini.
Oh my goodness, thank you so much. Thank you. Thank you so much, Dr. Bhattacharya. And honestly, it is also my honor to be a part of this, to be able to speak to all of you guys out there. And I'm waiting to share my experience and give you guys some light of information that we have seen and we have faced in the past few months. And I hope that it's going to answer some of your questions. But I am equally curious, like all of you are, to figure out the end of this, to figure out a vaccine for this, and to see where this takes us to.
I think first you will narrate your experience and then they will question you.
Yes, and Dr. Carr, I already have the list of questions. I can start discussing those as well,
Yeah,
or
yeah.
if you guys want me to talk about, okay, then as I answer the questions, I can also narrate some of my experiences along with it. I think that will be good.
Yeah, we'd like to hear from you your experiences and your journey through this COVID situation in US. Yeah.
Sure, sure. So I think my first question, which I had from the list, was asked by Shubhajit Ghosh. The detection of COVID by detection of different coughing sound is how much relevant? Is Shubhajit there with us?
I
Okay,
I
I
think
don't
he's
know
here.
if.
I think he's here.
Okay, okay, great. All right. So this is actually all the questions that have been sent to me are really, really good. And I will try to discuss each of them with some of the things that we have seen in our ER experience in our clinic. The coughing sound is not really main points of concern here because technically speaking, in the different age groups of population, be it like in babies or in adults, in younger adults and older adults, the way this cough presents is very interesting. For some people, they don't even have any cough or shortness of breath who have COVID 19. And for some people who have this cough, it's kind of like a dry cough. Some people call it like a gritting of metal kind of a cough. But honestly speaking, from my experience, anybody and everybody who is coughing, especially around this time, we are testing everyone, and almost 70% of the cases came back to be positive.
Oh my God.
I hope not. Yeah, yeah, and it is actually a scenario where we are told in ER repeatedly that to treat each and every patient as if they have COVID, regardless of whether they're coughing, whether they have fever, whether they have shortness of breath, because you'll be surprised to know how many patients we have seen who had none of these symptoms, but there was something very mysterious about the way they presented that provoked us to conduct the test. And one of them was actually a 29-year-old who was suffering from loss of sensation of taste and smell, and also mild slurring of speech. He actually had a stroke, and he was found to be COVID positive. And the reason being that recent data is showing that COVID 19, SARS-CoV-2 more precisely, the virus, when it infects your body, it can cause thickening or blood stasis, causing hypercoagulability, which causes stroke and symptoms of paralysis in a lot of people. We will talk about it as we go along. So Parno Odhikari's question was the next one. How accurate are the tests which are used to detect the COVID infected people? Is there any possibility of a person not having COVID infection being tested COVID positive? Well, I can say for sure that 40 to 60% of the tests are ambiguous. Rather, we say in our field or in our place that if a person tests COVID negative and we feel like they are showing the symptoms of shortness of breath, cough, diarrhea, of chest pain, of not feeling well despite of trying a number of measures, then they are COVID positive. So we are testing the other way around. But recently, also, I got some data from India, and I heard the speech from one of the doctors in Durgapur, not very far away from Kolkata, that they had two patients in their hospital who tested COVID positive initially, and they were put in the isolation units and every precaution was taken, but the doctor had his suspicions and wanted to do a second round of testing, and the 48-hour testing, which was done from a different lab facility, came back to be negative. So there is still a lot of ambiguity in this testing methods, and every day there's evolution of the testing methods, of the way the tests are being performed. Initially, the tests which we performed took about 5 days to get back to us, and now it's taking 24 hours. So the sensitivity and the specificity of these tests are still in question, but as long as we are getting back a result, we are trying to treat everybody like as if they have been exposed to COVID-19. If you guys have any questions, please feel free to interrupt and let me know, okay? So I'll go to my third question, which was asked by Anita Panda. What are the chances to stop the virus with vaccine, and what is the mechanism of destroying our immunity system by COVID-19? So let me tell you that I would be very honest about the data, the vaccination stuff that's going on all over US, and we honestly don't have proper answers to anything regarding the vaccine. Because in reality, a vaccine takes years and years to develop. Because everything, like whenever a vaccine gets developed finally, it has passed through certain stages, it has almost been tested in a good number of population, you have gotten back promising results, and then it is in the public. With COVID-19 raging all over the world, it is a very immediate concern rather than waiting for years and years for its development. And once it's developed, we would not even know if it's sufficient enough to prevent this disease from happening or rehappening again. So let's hope, I would say at this point, that some mode of prevention can come through with the vaccine because all over the world, a lot of people are invested in figuring out how soon can they result in making a vaccine. But I, as well as other doctors who have been in the field, my attendings, my other co-residents from all over the states, we are just hoping that a vaccine can do something because the myriad of symptoms with this disease seems to be very non-specific. And initial stages, I would say that, yeah, how is it destroying our immunity? Like, why is it so infectious or why is it so dangerous? Um, I know that all of you have had your fair share of reading about this virus, about the way that it infects the body, and how it shares almost 79% of the genome similarity to SARS-CoV, not the initial virus which caused the severe acute respiratory syndrome. So this virus also infects in three stages. The first stages is when it completely downregulates our immune system. Like it downregulates the production of cytokines, especially I don't know how many of you are aware of it because it's a mixed population of students. So interferon 1 is one of the cytokines that is very, very actively involved in regulating the immune system of our body. And the unfortunate thing with this virus that was seen was it's causing a downregulation of this interferon. And because it causes downregulation, your body is not able to fight it the way it should be fighting. So what I started seeing in an influx of the patients who was coming to ER, especially during the end of March to the beginning 2 weeks of April, all of them had a depressed WBC count. They had a depressed lymphocyte count. So initially we would be like, oh, if they are infected or if they are in an infectious state, then the WBC or the white blood cell amount in the body should increase because they are fighting the virus. But we saw that it was actually depressed and it was low in number. So it was causing a downregulation. In the second stage, it was very difficult, and that's when most of the problem arose. The immediate inflammation of the cells all over the body, especially the lung epithelium, was what we saw in our patients. The amount of destruction of the lung tissue because of this virus was tremendous. A lot of the people who were initially completely fine, they just had a high fever, but didn't even have the cough. In 2, 3 days, they came back to the ER with severe shortness of breath and needed intubation. At that time, we started checking some of the other interferons in the body, which are the markers of the immune system, which include IL-6, some of the inflammatory markers like ESR, CRP. Again, I don't want to throw in a lot of medical words, but this is like the point of medicine that I'm trying to um, tell you guys that there were some markers which we look at to see how the body's immune system is reacting to. And we saw that they are severely high. At that point of time, the damage was almost, I would say, irreparable. But if at this point we could intubate the patients and even put them into mechanical ventilation, some of them reverted back. And why did they do and why did some others not? It's very difficult for us to say because honestly, there has not been any correlation with who is able to go back to being normal and who is proceeding into a state where they cannot come back from. We had a patient who was 47 years old who fought in the mech vent unit with his intubated mechanical ventilation for 12 days, 12 straight days, and he recovered. He went back home. There was a patient who was only 29 years old who went into a severe state of acute respiratory distress syndrome, needed intubation. We were very hopeful that the patient is going to be able to survive the odds because she's young and she is her immune system is much better compared to a lot of older patients. But in the end, she went into something which is called a cytokine storm, multi-organ failure, and unfortunately, the patient. So there was a lot of discrepancies, and still today there are a lot of discrepancies in how to see the presentation of COVID as the evolution of COVID, and then who are the people who are going to come back or die from it still remains a mystery. So let's hope we can stop it with the vaccine, but I'm in no position to say if we can yet or not. Um, Another question, all these questions are interesting, but I found some of them to be very interesting, especially that is there any possibility that human body will be able to develop immunity as opposed to cold or influenza? So I just wanted to let you guys know that common cold and influenza really doesn't have any constant vaccine as per se. Like if common cold had a vaccine, then we would all be protected against it. Yes, flu has a vaccine, but vaccine changes every year because the genetic strain of the virus is prone to a lot of mutation. So every year, especially in US, North America, and Canada, you have to take the flu vaccine in the fall season, no matter what kind of profession you're into. So every year there is a different strain which is seen, a different vaccine which is being developed, and you have to take it every single year. So, and as of now, we don't know if COVID will be the same. It require um, taking vaccines forever and ever till the end of time. We don't know yet. So our minds are equally curious to find it out as well. Shrija asks how to stop the spread of COVID from patients to the frontline workers, and is PPE enough for this? Or what medicines can be taken for early protection? Honestly, PPE is right. PPE may not be the only thing that can prevent all the frontline workers, including the paramedics, the janitors, the staff, the nurses, the doctors, the each and every person who comes in contact with the patient, actually. But that is right now the only way we can think about prevention rather than suffering from it. And in terms of medicine, I honestly don't know because we were initially thinking that is hydroxychloroquine a good medication that can at least kind of be like a prophylactic, which can prevent us from contracting this disease. But I cannot say for a fact that it is the one which is the drug of choice because the trials for hydroxychloroquine has been they were insufficient data and it has been stopped. We still don't know much and we are not even prescribing hydroxychloroquine to any of our patients. We are rather treating them with the symptom presentation. And what does exactly PPE do? PPE is the personal protective equipment. So it gives you the first barrier to coming in direct contact with the disease. But yes, does that mean everybody who is wearing the PPE is not getting infected? Or does it mean the other way around, that everybody who is wearing the PPE and is getting infected? So there's always a choice because in New York, there were a lot of ER physicians who had the PPE, who had everything. And even one of our very own physicians who has treated maximum of this COVID patients, she was wearing the PPE, but she contracted COVID. And not only did she contract, her family members contracted too. And her dad was very, very ill with this disease and passed away. So it's different because PPE may not be enough, but right now it is the only choice that we have to protect ourselves. I see some questions here already. Shupratim has asked, what are the chances of doctors and other healthcare workers developing PTSD once the pandemic gets over? That is actually a very good question. And I have been talking to a lot of my friends who are in Michigan, in Florida, in New York, in California, and it's very difficult to say what they are going through because at this point of time, the only contact we have is through messages, through emails, through phones, just to make sure everybody is fine. But the trauma that people are bearing, I have a feeling that it's going to take a while. So, yes, for people who have seen people die in front of them, it can very well lead to PTSD. Rango asked me, ma'am, have you had any patient who once cured of COVID and discharged has again shown symptoms and has been admitted? Um, if yes, why? Or why aren't the bodies producing antibodies functional enough? Okay, so in this regard, I would say that I have not seen somebody who was admitted, discharged, and readmitted, but I have definitely seen pregnant patients. She tested positive for COVID when she was around 32, 33 weeks pregnant and her delivery date was scheduled at her 39th week. I would say around the time that she's supposed to deliver, she has already passed that state of 14 days of quarantine. So she came into the OB-GYN doctor's office. She got detected, and then she was sent home, 14 days quarantine, and even her husband was quarantined with her. At the time during which she delivered the baby, she had other complications, but she also had fever. And just to make sure that she still doesn't have the disease or what exactly is going on, and given the fact that we're testing almost a lot of the patients coming in for any of the operations, we're testing them. She was found to be again positive for SARS-CoV-2 or COVID-19, and even her baby tested positive for it. My friend who has suffered from COVID-19, she told me recently that she got her antibodies tested and she suffered from it in early March. She was one of the first people I came to know that had COVID-19. But she got tested for the antibodies and she has both IgG, which is showing that you were once infected, and she also has IgM, which means that she is still in infectious state. So we honestly don't know what's going on. Are they getting reinfected? Is it staying in the body for a prolonged period of time? What exactly is happening, we are not sure yet, but we have definitely seen patients who we have tested, who we have sent home, but some of them have come back with severe disease, retested positive again, and some needed intubation right away. I did see it, but the answer as to why this is happening is still not clear. Um, let's see. Then I also have Shampurna asked me about, can you please tell us, does an antibacterial like hydroxychloroquine act against? Well, hydroxychloroquine is not really an antibacterial per se, but hydroxychloroquine showing any sort of activity against COVID, like I was just mentioning, that we are not even treating our patients with hydroxychloroquine anymore because in a lot of these patients, I will tell you a very interesting thing that we have seen. It it poses a very bad risk of going into cardiac arrest. We have seen it in patients who are usually 40 years and above, and they have a positive family history for heart diseases. Um, so we have seen that hydroxychloroquine, the compound, it causes an elongation in the, you know how like the ventricles and the atrium, they're all involved in the contraction of the heart, and there's electrical impulses that are being delivered from the atrium to the ventricles for making the heart contract in rhythm. Hydroxychloroquine has actually been shown to interfere with this electrical signaling pathways. So in patients who are COVID-19 and you are giving them hydroxychloroquine, they are causing a very bad risk of going into cardiac arrest compared to other people. So, and we have not really seen any complete cure with patients who have had hydroxychloroquine. So in our hospital in Illinois, hydroxychloroquine is not being used anymore. Even in Michigan, I was just talking to one of my resident physician friends today. He mentioned they are not using hydroxychloroquine. And I don't know why I like this question because I had a very interesting question from Shemonti. She said that I would like to know whether corona can spread after death of the patient from the corpse or not. So we did have several cases in which we treated the patients who were coding on the table. Coding means that they're almost like the electrical activity of the heart is almost borderline abnormal, and many of them may not make it. And we have treated patients like that. And the protocol for treating patients who have the COVID-19 right now, but they are not really breathing anymore, is the same as you would have done anybody who is breathing because a virus is actually a non-living particle. It only needs a living host for replication. If it can survive on plastic, on metal, on any other surfaces, then it has a very high risk of surviving on patients who are currently dead. So I don't know if you are aware of it, that in New York as well as in Chicago, a lot of these people, a lot of the dead bodies which came out of the hospital were taken together and they were taken to the special place where they were isolated and there was no risk of transmission of this virus. So they were all taken to a different area of the hospital where mucosal surfaces, mucosal membrane, which involve your gut as well as your epithelial surfaces. But contact has also shown to be an important mechanism or mode of transmission. That's why we are asking our patients, asking our family members, our friends to always, no matter where they are going right now, wear a mask, wear a pair of gloves, even when you're going to grocery stores. All the precautions as soon as you come home, just like I know all of you guys do. It's in our culture that we leave our shoes outside of the rooms that we enter. So make sure that there is no contact with anything that you have worn in a place which might have also had those who could have been the carriers of this disease. And I don't know if all of you read about this recently, that there has been a list that was published about how long can the virus survive on different surfaces. And a lot of us use online shopping, right? So we have all these boxes delivered by Amazon. We have all of our good stuff coming from different places. But it's always recommended right now to keep these boxes outside of your homes at least for 1 to 2 days before you take them inside home. You never know the mailman who is carrying it, the person who manufactured it, the person who transferred it, what is the mode of transmission. So keep all these boxes outside because it has been shown that the boxes also, the virus can live for approximately 1 to 2 days. Most of the surfaces, including doorknobs, jewelries, stainless steel, up to 5 days. Things like soda cans, then refrigerated bottles. I don't know what is the connection, but refrigerated bottles, soda cans, they survive for up to 8 to 10 hours and not really days. I don't know exactly why, but I read about it. And an interesting thing that I would want to share with you guys that one of the studies that tested the shoelaces of the medical staff in a hospital in China, in the ICU unit, they started testing the shoelaces. It was a very interesting study. It was found that half of those population actually carried nucleic acids from the virus. It came back positive for the nucleic acids from the virus. But it isn't clear if those are the degraded viral particles or they are active or they are the pieces that cause the viral infection. However, when they compared it to the people or the staff in the general ward, which had milder cases, it was found to be much less. So we don't know. Maybe in the ICU units where the amount of the viral load is much, much high, maybe everything that we are wearing to see our patients, including the caps, the gowns, the Face shields, everything is probably carrying some amount of this virus, viral particles. And I would say that if there are anybody out there who are from the profession of medicine, if you are going to see patients who are coming in direct contact with your patients, I would say carry a different set of clothes for when you're going to the hospital so that there is no direct contact with whatever you're wearing from outside to the stuff that you're wearing inside the hospital. And same applies to when you get out of the hospital. Just we always carry this extra set of clothes, an extra pair of shoes that remain in the on-call room. So once we go into the hospital, some people take a shower, but we usually take it before we leave. So we change into this attire, which is hospital provided, or it can be your own. And then we have to wear the N95 mask, the face shield, and if we are going into the rooms of the patients while we are going in to see our patients, we have to wear the gowns, we have to wear the boots, but nothing else. And once you come out of the room, everything needs to be sanitized. It can be the Clorox wipes, it can be any sort of alcohol sanitizer that you use, but everything we sanitize, and then again we go into the next room of the patient. And before we leave the hospital, we have all of these stuff changed, change into a completely different set of clothes, and then come back home. So this is how routinely we are following in our hospital. This is the method that we are currently trying to use. Um, and then I've also seen some questions where the PO2 level of the asymptomatic patients are being questioned. I think it was, let me see, Aniket Bose. Why is the PO2 level of many asymptomatic patients about 50% and they are still not severe? Does this virus change the physiology of the cells? Or the PO2 FiO2 calculation is getting incorrect due to this virus. I know that you mentioned that this is a citation from a New York State General Hospital, but let me tell you something. Each hospital has own, their intensivists, the people who take care of the patients in the ICU unit. They have their own methods, own protocols of intubating a patient, of putting a patient in mechanical ventilation, of seeing if they need high flow, different ways, different methods. So to understand from a layman's perspective, when a patient comes in and is having shortness of breath, that means the oxygen saturation in their body is lower than what it should be. PO2 is basically the amount of oxygen that is being carried by the cells in your body. And if it is 50%, that means only 50% of the amount that you're breathing in has the oxygen that has the capability to go into the brain, kidneys, heart, and all the essential organs to keep them working. When a person comes and is having active shortness of breath, it might be that the oxygen level is only 90%. Doesn't have to necessarily drop down to 50%. A regular, normal breathing person who doesn't have asthma, doesn't have COPD, should be having an oxygen saturation of 97 to 98% on room air. But if that kind of person comes into the ER or comes into your clinic and is having an oxygen saturation of 99.0%, that is enough for us to know that this person is severely affected. We would not even wait till it drops below 90. For somebody who has asthma or severe respiratory illnesses like chronic obstructive pulmonary disease, any pulmonary fibrosis, for them, we usually think that even for people who asthma, unless they are very severely asthmatic, they should be 90 to 92% on room air if they are not wheezing. If they are wheezing, we generally think it is around 88% to 90%. And if it is below 88% for any patient across the board, having respiratory illnesses, having no other respiratory concerns doesn't matter. They are at that point of time going into a hypoxic state. That means that the rest of their body is not receiving the amount of oxygen that they should. I don't know where exactly this PO to 50% came along because it would be severe to say, I have not seen in my hospital any asymptomatic patient who has a oxygen saturation of 50%. But yes, the calculation of how much oxygen you're giving through the tubes and how much are you able to breathe in by yourself is calculated differently in different hospitals. But is COVID the reason that this calculation is getting changed? Is still a mystery. Because for some people, what we have seen is putting them in mechanical ventilation is actually causing more harm than good. People who do not need intubation, if they are intubated and they are put into ventilators, then the extra amount of oxygen that you're pumping into the body is causing the lungs to blow out. This also causes the adult respiratory distress syndrome. So there's always a fine balance, and it has to depend on the intensivist who is taking care of the patient as to feel and see whether this patient needs to be intubated, needs to be ventilated, or can we just put them in nasal cannula, increase the amount of oxygen, and see how the patient progresses. But it depends upon the complete judgment of the intensivist. Full respect to them. They have seen a lot of patients who are surviving or who are not surviving. But I would really say that my little piece of information that I got from in New York when there was a lot of these deaths in the ICU, it may have been due to putting people who did not really need mechanical ventilation into the mechanical ventilation, which instead of causing benefit, it caused more harm and caused like a full destruction of the lungs. So that balance was gradually understood, but in the initial stages, I feel like that was a big mistake, which a lot of the places did because this disease is so unknown to us. Okay, I do have some more questions here. I see, I don't know, some I cannot, but some I can see. Maria, she asked me what kind of precautions can be taken for patients who might be suspected of having the disease but show to be asymptomatic. So all of us are actually, we are all who are sitting today, we are talking to each other, unless we're having high fever and cough, we are all asymptomatic. We're not showing any symptoms. But does that mean so out of 85 people who are here today, I would say a good amount is probably the carriers. This is what we have seen. And it's crazy to think that way, but I would say that almost like 50% of the people, especially the young adults, we are all carriers of this virus. And people like us who have been exposed to COVID patients for like day in, day out in different settings, I have a feeling that we are all carriers, right? So, and we thankfully we're not showing symptoms. Even if we show like a sneeze or a cough or a headache, we tend to be like, it's okay, it's allergies. So we will never be able to understand the fine line between are we showing symptoms or not. But the precautions is very important. What are the precautions that we can take? Especially if you have elderly people living with you immediately in the immediate surroundings, including your grandparents, including your parents, you have to make sure that if you've had any known exposure to someone, quarantine yourself completely isolate yourself as if you have the disease. I would say we are going for 14 days, but technically 14 days is not even a good number anymore. But quarantine yourselves to the extent that yes, you definitely have to come out to talk to them, but maintain the distance. You know why they say that it's 6 to 8 feet? Because even respiratory droplets have been shown to travel as far as 2 to 3 feet max. So a good amount of distance between the people that you're talking with, making sure whenever you're sneezing, you're coughing, you're using your elbows, and you're just trying to protect as much as possible. Does that mean it's not going into the air? No, it is. But as much as you can, wearing a mask and making sure that it's kind of sealed so that not a lot of the air that you're breathing out is escaping, and washing the hands is important regardless of whether we are during the pandemic times or not. Washing hands is like the basis of hygiene for anybody and everybody. But given the fact that now all of us are thinking about it all over the world, definitely wash your hands. And another thing is, we really don't know how long can they survive on our clothes. The, the washing of the clothes, the bleaching of substances that we think are contaminated, yeah, some people do that, but washing is more important. Disinfecting, and for anybody who has suffered from COVID, we send them like lettered envelopes saying that they have to not only wash their clothes every day, make sure that all the covers of the furniture, the carpet of the floor, everything gets disinfected. The shoes, the bottoms, everything, because you are trying to do your little bit to prevent the transmission. These are some of the precautions that we are taking here. Let's see if I can see something. Didmallo has asked me, ma'am, how does other complications like high blood sugar level stimulate the infection readily? Thank you for asking this question, Didmallo, because the one of the first patients who came into our ICU was a patient who was initially admitted, 35-year-old girl, who was admitted for diabetic ketoacidosis. For people who know what is DKA and for people who don't know, this is most people who have type 1 or type 2 diabetes, they are at a very high risk of going into a state of DKA. Where the insulin resistance is increased in a way that the blood sugar levels beyond control. So when a 35-year-old girl is admitted in a hospital for elevated sugars and feeling very sick, and during those times, they feel very, very sick. Um, they were feeling very sick. She was feeling very sick, and she was given all the protocol for giving her insulin, making sure that she gets all the electrolytes that she needs, and giving her fluids to bring down her sugar levels. But somehow she wasn't improving, and her oxygen requirement went up from being on room air to 2 liters, over the night 6 liters. Next day morning she was on 15 liters, but she did not have any asthma or any sort of respiratory illnesses. She just had diabetes mellitus. And so it was, I think it was towards the end of February that this happened. At that time, COVID-19 was not such a big deal yet in the Western countries. But um, because of her oxygen needs increasing, we tested her. And she was one of the first people who tested positive. What happened was, now we don't really know that what exactly was she infected with the virus, and that's why her sugar levels were not adjusted and she was going into this DKA state. It's not known yet because a lot of the people who are on insulin because of diabetes, they are at a very high risk of developing DKA, regardless of whether they're suffering from this viral disease or not. But not everybody requires a high amount of oxygen. Somehow, this girl, whose entire family by that time was already infected, we had her mom, her dad, both of them were in ICU at that time because they were both suffering from COVID. And she was the first person to be admitted. Um, she had the diabetes as one of her underlying risk factors. And that's when the conclusion was made that this theory, these are all theories, these are all hypotheses. We don't know yet. I wish I could have said that this is exactly how it happens, but unfortunately, we don't know much. But right now, we are suspecting that people who do have underlying risk factors, they are at a higher risk of contracting this disease because of the overall immunity. Because I don't know if you all know that diabetic people are considered to be immunocompromised. They are at a high risk of any infections, be it bacterial, be it yeast. They live an immunocompromised life. So for them to contract this disease is about, I would say, 5 to 6 times higher compared to any other normal human being. Normal in the sense who doesn't have any other risk factors. So I would say that we have definitely seen it, but we are thinking that it's maybe due to the immunocompromised state that the virus finds its host to be weak enough to replicate very easily. Um, then Ritwik said, it is said that COVID-19 can't affect animals other than humans, with an exception of a tiger. But is it completely true that our pets are safe from COVID-19? Ritwik, this is a very good question because a lot of the people in United States, obviously in Kolkata, we love pets and we live with pets. But in US, with the rates of depression and mental illnesses being so high, a huge segment of the people or the population, they live with pets in their house, service pets like dogs who are the service dogs and stuff. So during this time, a very interesting thing happened. My neighbor's cat, she went into it's a little cat, and she went into kidney failure all of a sudden. She's a kitten, 7 months old, and she went into kidney failure, and her doctor tested her for everything, and she was found to be coronavirus positive but not COVID-19. She had contracted the what is called the feline coronavirus. And one of my recent news that I heard was one of my friend's aunt. She lives with a golden retriever. Her aunt had it, and she has been living with this golden retriever for the past 2 weeks that she suffered from COVID-19. But the golden retriever is fine as of now. As much as we know, she's eating okay. She is doing her regular business and stuff. And the little kitten who suffered also is back to being normal. And I would like to know if they are seriously protected or not. But I'm actually equally curious. I don't know yet. Let's hope that they don't, because otherwise we would have also seen what I think is we would have seen a surge of these patients even in the veterinary clinics going all over. We have a lot of this vet clinics all around us, but we have not seen a resurgence of patients, of cats, dogs, or other pet animals who are coming in with any respiratory syndromes or anything. But I can only vouch for the place that I live in. We have not seen anything like that yet. Um, let's see. Is there any relation of COVID-19 with blood groups? Like a special blood group seems to be affected by COVID-19 more than others? Actually, not. Initially, it was told, like I read it somewhere, that A positive blood groups are more prone to getting infected. The funniest thing, if I tell you guys, I actually had this, I made a graph of all the people in our hospital and our clinics who tested positive for COVID. And only 5 or 6 are A positive, but there's a lot of people who are O negative, who are B negative, who are A negative. There is AB positive, of course, they're O positive as well, but um, I cannot say that it's only seen in positive blood groups. Technically speaking, I have seen more in negative blood groups. That's interesting, actually. Let's see. Bibopom asks, regarding the question of oxygen transport, is it the PO2 that's going down to 50 or the percentage HPO2 that's going down to 50? The second scenario is catastrophic. That must be indicating severe hypoxia. Ma'am, can you please clarify? Yes, so this is exactly what I was talking about. So yes, they will come. It cannot be that their PO2 is 50% and their so my question, like the question that I received was that there was PO2 of certain asymptomatic patients who were 50%. And that's why I needed a clarification because that is impossible. Nobody can be asymptomatic with a oxygen saturation level of 50%. But yeah, PaO2 50, yes, we have seen that. In fact, one of the patients was the last patient who I saw before I went into newborn was 43. Those patients are very, very much, they're very common to see like a PaO2 level of 50 mmHg. And that's not only in COVID, you can see it in any sepsis scenarios too. And those are the typical scenarios in which they require intubation, yes. And however, that level is not really an indicator of whether a person has how severe is the disease. Because even with people with a PaO2 of 70, they have died. And people who had initial PaO2 of 43, went back home after 4 days. Everything was good. So our intensivists, we had a special class with our intensivists who told us, please do not just confine yourselves to values, to percentages, to calculations. Look at this disease as something that we are not sure of. Treat the underlying causes, treat the underlying symptoms. The rest of it, we will manage as we go because the numbers, the percentages are not uniform throughout. I hope that clarifies a little bit. You know
So
that COVID-19 can be.
Post-op Banerjee.
Sorry?
So there is a question.
Yes. Yes.
Um,
Yeah, I can see the question. Yeah.
Post-op, would you like to ask the question, or you have prefer to have that from the chat box? It's a question that we know that COVID-19 can be severe in hypertensive patients due to the fact that it binds with the ACE2. It also said that there is no sufficient clinical evidence to prove that. What is exactly the association?
Yeah, actually, in fact, this has been a topic of controversy with this the ACE2, which is the angiotensin converting enzyme, and the medications, which are the ACE2 inhibitors that people usually take for the antihypertensives. There has not been any correlation because these are two completely different ACEs. I don't know if you're aware of it or not, but these are completely two different ACEs. And most of the patients, where initially they were thought to have a correlation of having like ACE inhibitors as one of their antihypertensives that they have in their list, who seem to contract COVID-19, are actually proven to be completely wrong because today when we see it, there are people who are not requiring any ACE inhibitors who are contracting COVID-19. And yes, people who are taking ACE inhibitors, they are also contracting COVID-19. Does that mean there's any sort of correlation? I personally don't think so. And anybody who is taking an antihypertensive means that they are at a risk of going into stroke. They are at a higher risk of developing blood clots. And COVID, the virus, SARS-CoV-2, loves to create a huge inflammatory response in your body by causing havoc throughout your system, whereby it increases the clotting tendency or the hypercoagulability of the blood. And we have seen that. And patients who are taking antihypertensives can still suffer from strokes, and those have been linked to COVID. I have not, or in fact, we had a lecture recently by one of our attendings regarding these medications, and he personally told us not to just look at it as initially. I know that ACE2 was considered to be one of the big hot topic, but as of now, as of today, I have personally not seen much correlation with it. Anything else? I think I see a question about should ICMR continue to recommend hydroxychloroquine to doctors as a precautionary measure? I was talking about hydroxychloroquine. I think it's Siddharth. I don't know if you have if you listen to that part. It's basically I was just trying to say that we are not even prescribing hydroxychloroquine anymore. It's supposed to cause the terminal glycosylation of the ACE2 receptor. So this is a drug which is used in a lot of inflammatory conditions like SLE, rheumatoid, and also we know that quinine can be used in malaria. But in COVID-19, we have made like there's different research trials that are going on. Initially, we were thinking that can this drug be used as a prophylactic medication against. And I also remember some of my friends who started calling in these medications for each other. We were like, should we all take it because we're all working in the hospital? Should we just take hydroxychloroquine and protect ourselves? And this idea was severely dismissed by our attendings, saying that no, there has been no correlation so far. And there has been probably, but there is not like a positive amount of data to show that people who don't take hydroxychloroquine go into this ultra inflammatory state and COVID 19, but people who take it are completely protected. So we don't even recommend people taking it. And like I was saying earlier, hydroxychloroquine is a drug that causes QTC prolongation in people, especially if it's a drug which can cause a lot of drug-drug interactions. So we are being very skeptical, and we are taking a lot of measures not to introduce anything into your body that can cause this drug-drug interactions that can cause cardiac arrest. So as of now, we are not giving ACQ. Vapopalm asked, what is the protocol behind management of septic shocks, which may be a result of severe COVID-19 infection? Vapopalm, I would like to share this information with you. I'm actually really happy to share it because one of the patients I admitted overnight, she came in with just saying that she doesn't even remember why she came to the hospital. Her caretaker brought her, and this was actually my case report that I presented in morning grand rounds to my colleagues and other attendings. This was a case of a patient who was suffering from mild dementia, but her caretaker brought her in because her oral intake was very poor. She was not able to eat well at home. She looked sickly, and her caretaker thought that she needs to come to the hospital. But other than that, the caretaker lives with her, and she's the person who goes to the grocery stores once a week. We have had no known exposure so far to COVID. She came into the ER, and I still remember she sat there saying that she doesn't really remember. And I called her daughter, and her daughter said that her mom suffers from some dementia. She's just 77-year old, but they have a family history of dementia, so like early onset Alzheimer's. But she recently suffered from a UTI. That kind of made me a little nervous that people who are a little more demented than usual having a UTI, that's a big risk. Elderly people go into sepsis very easily with just a normal UTI. So we rapidly checked all her blood levels and did all this workup. I don't know because I at that time I want to share this because I was the only resident in the floor and there was nobody else and all the other doctors were so busy with intubating, putting central lines and everything. And I just asked myself the question once before sending out these workups that she's probably suffering from some sort of infection. Should I still send a COVID panel and do all the other inflammatory markers test? Something in me just said that yeah, elderly people, probably UTI, demented, just send in everything. So I sent all the tests workup, and her initial picture of sepsis criteria was not meeting at all. Her vitals were stable. She was not on oxygen. She was not tachycardic, not tachypneic, meaning not increased heart rate, not increased respiratory rate. Her white blood count was actually, I won't say it was depressed. It was like within normal limits, but on the lower end of the normal. And within 2 hours, her oxygen requirement went up. She needed 2 liters, but she was otherwise fine, talking, sitting, and just chatting with us. We were all like, okay, should I just tell her daughter that we are sending a COVID test because I don't feel good about this patient. She is like 2 hours before she was okay, but now she's a little sick. Her blood pressure at that point was on the lower end, so she became hypotensive pretty soon. She needed a lot of fluids. At that time, her chest X-ray, which we did, came back. I wish that I could have shown you guys at how the chest X-ray looked like. It looked like as if both the lungs had so much of haziness and so much of infiltrates. I was wondering how come she's not coughing or she doesn't even want to throw up anything. She was not wearing any mask. She didn't have any other precaution that needed to be taken. I immediately put her in the isolation. I was like, I don't care about what comes back positive, negative. She is probably going to go into a shock right in front of me. Within 2 hours, she went into 8 liters with 2 boluses of fluids, with 2 liters of fluid. Her blood pressure was still sleep it okay, but there was not much change. Within an hour or so, we started we took the precautions of like putting the patient in a negative pressure room because the way that her chest X-ray showed and the rest of the inflammatory markers showed her ESR, CRP, they were all very highly elevated. And there is a marker that we usually check for the clotting, D dimer, for the clotting tendency, but that was elevated. And and obviously she had her urine cultures showed that she was infected with 3 different bacteria. We started her on a very broad spectrum antibiotic or kind of IV antibiotic. But at that point, we were like, what should we do? Should we just manage her like a normal septic patient? Like, what else can we do? She's going into respiratory failure, right? She might need to just brought her in. Her daughter asked like she was fine because when she talked to her mom, she was okay. And now we have to tell her that her mom is going into a septic shock at that time. So within the next day, she was so from 8 liters, she needed 15 liters. She was going into multi-organ failure. She got intubated, but at that point of time, even our intensivist was like, I don't think that she's gonna make it the way that she is deteriorating. The only thing that I saw that they added to her treatment regimen, they did not even try any other drugs other than managing the sepsis. But in reality, people with septic shocks, they die regardless of whether they have COVID or not. So I don't know if it was the underlying COVID which made her situation worse because she was not showing the symptoms right away. That might have been the reason that her immune system was like very depressed. She was not even coughing anything. But she was managed like any other patient who was into septic shock. Precautions meaning the contact, respiratory droplets, airborne. She was in a negative pressure room. But then, other than that, like nothing really. These are the only things that we did. And we did see a lot of shock like pictures in this patient. What is the cause of death in comorbid patients? Is it the inflammatory response, indirectly leading to the organ failure, or the virus itself causing the organ failure? I would say it's the inflammatory response because if the virus would cause the multi-organ failure, then anybody and everybody would have had this, would have gone into a shock. But it also depends again, like it affects in 3 stages. The third stage, where the cytokine storm happens, that's the one in which there is a hyper inflamed response from your body. And it's difficult to say because some patients who we see dead on the table on arrival, we have had no time to even see like what exactly was the cause of the infection of the death. But some of them have died even with a cardiac arrest. Some of them had had a hemorrhagic stroke. So not necessarily it is all related to the virus causing inflammatory response alone, but it's definitely related to the body's overall immune system and the hypercoagulability of the blood as well. I think Rajnali had a question. The COVID-19 vaccines are under trial, which are under trial are they given active COVID patients or given in normal people without infection as a prophylactic measure? Very good question. Actually, I did some research for myself too because I was very interested in finding this out. And uh, so I don't know how much are you guys aware of these clinical trials per se, but in the US, there are 4 companies as of now who have taken a lead in producing this virus vaccines. One is a US-based company called Pfizer in association with a German-based company called BioNTech, and doing this trial in association with NYU Langone Health. So I am just telling you about their data because I think that will be one of the main pathfinders in our time of so much of worrying. They are saying that over the board across the different nations, the initial candidates who will receive this vaccine should be young, healthy, have not had any exposure to COVID, are not currently suffering from COVID. They are the ones who are going to get the immediate vaccine to see the trial, and then they will be checked for the next 24 to 48 hours of seeing that if they are developing any new reaction to that. However, the eligibility of these candidates will a little bit depend upon each of the hospitals or the healthcare systems associated in the areas because they are the ones who best knows in which population they see this most. But most likely, the last news that Pfizer just released was older adults in the age of 65 to 85 will only be immunized with a vaccine candidate once the testing in the younger adults between 18 to 45 has provided some good evidence for safety and desired immune response. I hope that kind of answers your question. And we can never give any vaccine, be it COVID or influenza or anything, to anybody who is currently during the state of infection, like while they are infected. We have to wait till the infectious state is gone, or we have to give it even before they are exposed to infection. So that is basically what a vaccine should do. Sneakto said, without any treatment, what is the approximate mortality rate of COVID-19? Again, that depends because there is no, I will not be able to say any mortality rate as of now without treatment because we are not sure what exactly we're treating. Are we treating the symptoms due to the COVID-19 or what exactly are we treating, right? So it's difficult for us to say that if what we are doing for a patient is no treatment or is that treatment in some way contributory of something. Uh, in May 19, as of May 19, the global case for the fatality rate for people who are less than 60 years was around 1.5%. Greater than 65 years was 4.5%. And greater than 80 years was 13.4%. But that again depends on this gives us an overall picture, but it depends on area to area because in our area we saw a lot of the people between the age of 20 to 50 who had died from this disease, so the percentage was a little skewed. But we don't know if they had received no treatment at all or has there been some sort of something. Like I know for a fact that all of us who are working in healthcare, who are asked to make sure we're taking vitamin C enough, people who are in fact in the hospital currently suffering from COVID-19 to get vitamin C infusions. And this is just like making sure that their body is kind of trying to fight some sort of immunity. I don't know if you guys also know about remdesivir. That's another drug that was used for Ebola virus. That is also in kind of in trials right now. I know that it's used in compassionate care in our hospital, but as of now, there has not been any good amount of information that I can share that people who have been treated with remdesivir have shown better chances of approval. And I think I did see a question in this regard about the treatment from one of the students who said that Dev said, why are we not interested in the immunology of patients who have recovered? And why are we not using that technology as a remedy for affected ones? So that is a very good thing. And I would say that our hospital is doing a research trial, another clinical trial in association with Mayo Clinic about the convalescent plasma from patients who have suffered from COVID-19, have recovered, and now they're symptom-free. They have been tested again and they are negative. We have procured 20 of these patients recently who have donated their plasma that are used in the treatment of COVID-19 in the hospital. And I was talking to my attending is very nice, so it was very generous of her to share the information with me today in the morning so that I can tell you guys because this trial is still it's very much under the covers because we still don't have enough data. But as of now, from a very raw data analysis has shown that out of the so there are it was just tested in 5 patients so far. 15 to 20 patients have donated their plasma, and we have tested it in 5 patients. Two were in they were not in ICU, they were in general wards. They have actually gone back home and they are okay right now. One person in ICU passed away even after getting the plasma. One person is still fighting. And the other person, who was a young girl, she suffers from sickle cell crisis. And that's why she was targeted as one of the primary recipients of the plasma. She has not had anything that I can say that she has improved or she has worsened. She stayed the same. She's still on day 12 of the disease. She has the dry cough. She has a little bit of shortness of breath here and there. But other than that, I can't say that she's completely cured. So, yeah, people are testing the immunology of these patients who have tested positive, they have recovered, and now we're trying to see if at all this is helping them in the long run. Let's see, I'm keeping my hopes high. Let's hope that it can. And honestly, people have been really generous in donating their plasma too. Srijani
Thank you,
asked that,
ma'am.
yeah,
Hello,
you're welcome.
myself Devduti. So
Yeah,
I don't mean about the plasma therapy, but I also want to know about
yeah.
if we get any clue from their genome or proteome that they have any specific traits that will help those peoples that have cured from that disease, and can we apply those traits by recombinant technology in the suffering
Future?
patient?
Yeah. Yeah, I think that's a thank you. That's actually a very, very good thing too, because I can say something that each of this the testing for this genomes, the proteomes, and all of these are going on at a very, very high scale all over the world, not only in the US, everywhere. And the way that you are thinking, I'm pretty sure that a lot of the scientists are now thinking about it as well. The reason that we haven't been able to publish any data yet is because the maybe what I think is the non-specificity in the attachment in the infection of this virus. There has not been a clear-cut pathway of showing how this virus is causing the infection and how this virus is being eliminated from our system. But can it not happen in the future? Of course. And I am a very optimistic person always. So I'm hoping that with minds like yours and with bright minds of people all over the world, we can procure a cause of figuring this thing out and figuring a way to stop this virus from being so deadly. And I think that it's very much possible. Epigenetics also play a very important role in this scenario. And I think there's still a lot of study that needs to be done. But if there's anything that comes up that I become aware of, I would love to share with all of you. Okay? Is that
Thank you, ma'am.
all? Of course, you're welcome. Srijoni asked in homeopathy medicines like arsenic album and certain other combinations containing extracts of quinine, tulsi, turmeric, and many more are used for all viral infections. Can we start using it as trial? Many of us just ignore it, saying that homeopathy is not effective. But actually, they might work as they are derived from natural sources. I agree because why do we use these natural sources? Again, these natural sources are nothing but they are helping our body every day fight a number of infections. And they have been a source out there for long, long periods of time. I know for a fact that whenever I go home to Kolkata every day in the morning, my mom and dad make sure that I have this turmeric extract being put into my mouth, which I hate, but I do take it because it's antioxidant. And in the future, it might help me fight against a lot of diseases which we are maybe not even aware of right now. Why do I take it? When I belong to a family of doctor, virologists, myself being in medicine, I would be like, it doesn't have any role whatsoever. But it does. It has shown. And what you're saying currently, this mixture component, Ayurvedic medicine, herbal medicine, or any sort of medicine which is a little out of the regular allopathic medicine stuff, medical stuff, it's hard to try our clinical trial on those because a lot of people have different ways of thinking into it. And like you said, that they might ignore it, thinking that, oh, they are such like stupid thoughts. Who cares about those? But why were they used long, long time ago when people did not have vaccines, when people did not have any of these artificial methods of curing diseases? They were used to mainly enhance the system, the immune system. So I would say that rather than being a reason of killing the vaccine, it would kill, sorry, not the vaccine, the virus, it would be a process of increasing the immunity in our bodies to fight the virus. So I don't know if they will use it as a vaccination trial, but they can use it as a trial, which I honestly think, and you should write out something like this that can be considered that if we do a study, a clinical study based on people who are having, who are managing their health using these stuff versus people who are just regularly taking medications and not really exposed to these. And there can be a study, and I would be looking forward to it. That's actually a very good suggestion. Let's see. Dango said, ma'am, please do tell us about how you personally have been coping with this pandemic and how it has changed your schedule, if at all it has. So thank you for asking, because a lot of the times we forget that we are also human beings. We also have weaknesses. We also need to stop once in a while to take care of our own health. And for me personally, in my last few months, as a resident physician, we're supposed to rotate through different departments because we have to have an overall experience of treating patients of all age groups. So from January, I was on nights, then I was on clinic, I was on ER, I was in inpatient ICU, I was in newborn nursery. So right now I am in newborn nursery. And I have seen patients all from different age groups who have suffered from it. How am I protecting myself? I'm actually not, I'm trying my best to keep myself as like taking all the precautions as much as I can, making sure that everything that I am wearing to the hospital and back are washed, making sure I am always washing my hands. I'm wearing an N95, and on top of that, I'm wearing my surgical mask. And we always have to wear a face shield. And we have to wear the gowns only when we're going into the rooms of the patients with COVID-19. But sometimes it's challenging. It's actually some of the times when I come back home and I wonder, like, wow, today almost every patient that came in was COVID. Or, well, we don't know yet because the tests are sent out and then we have to wait for 24, 48 hours. But I have a feeling, and I discuss it with my friends, that it was a crazy day. And what our attendings, what our family members, our loved ones, and I'm extremely lucky that I live with somebody who takes care of me 24/7, making sure I have food, I sleep enough as long as I'm back home. The only thing that we can do is we have to take care of ourselves, make sure that our immune system is not compromised. And how can we do that? By eating healthy, by making sure we're getting at least 6 to 7 hours of sleep every night. And on the weekends, like I had back to back, I think 3 to 4 weeks that I had all the weekend. I didn't have any of them off, but thankfully now I do. And we are lucky that our rotation schedule did not get changed. But a lot of my friends, they have been pulled out from their rotations and were told that they cannot do any other rotation other than inpatient ICU and ER. For us, we are taking turns and going through each of these facilities so that everybody is sharing their responsibilities. But unfortunately, the month that I was in ER was one of the heaviest months because a lot of patients, it was during April to like early May. So I'm trying my best to keep me and my friends, my family, um, out there not too worried by just making sure that I'm taking the right precautions. And as soon as I'm developing some symptoms of like headaches or cough or allergies or anything, I just go to sleep. Like I need to sleep it off to make sure that I'm well enough to go to work the next day. And we are told again and again that if we have fever, if we are not feeling well during this time, we should definitely let our preceptors know. And they're helping us out a lot. So I would say that I belong to a place where I'm very lucky that I have all the support that I need. Um, Orpon asked me what kind of general treatment procedure are being taken or being used who are already tested positive. So if it depends upon like what are the presenting symptoms and how severe is the disease. Well, if there is suppose like we do a lot of telemedicine right now if you're seeing in the clinic. So suppose if I will give you the scenarios of three different cases. One case can be that I am doing telemedicine. So from our clinic, we usually talk to our patients over video call to see how they're doing. And they are telling me, oh, I'm really sick. I feel sick. My fevers are really high. I don't know what to do. And I have kids at home. I cannot just go to ER. I cannot expose other people. And for them, the treatment would be making sure that they are taking antibiotics. We are making people take azithromycin, depending upon the fever and the dry cough, the symptoms basically, encouraging them to take a lot of vitamin C intake and letting us know if at all they're having severe symptoms, then going to the ER right away. Otherwise, stay at home, isolate yourself, take a lot of vitamin C, 7-day course of azithromycin. The fevers, nothing can cause, actually, fever is a good sign. That means your immune system is fighting. So 7 to 8 days, some of these patients have had fevers for 3 to 4 days almost. So they are just managed conservatively at home. Other than that, if there is somebody, the second case scenario would be someone who was initially okay, tested positive, but suddenly started developing shortness of breath at home. We are encouraging people to take these small pulse oximeters, with which if they put their finger on it, they can test oxygen saturation all over their body. So we're encouraging these people to take these kind of pulse oximeters. And as soon as the oxygen saturation is dropping to 88%, they are told to go to the ER right away because they would need more help than just being at home. And the third scenario would be somebody who is already in a state where she or he has pneumonia, has a very bad chest x-ray, is already brought to the ER, admitted or an ICU. For them, the treatment is just managing the sepsis, managing their health, using fluids, oxygen, vitamin C. In some cases, like I was saying, remdesivir is used as a compassionate care medicine. It's very, very costly, but we're using it in some patients. And now with the convalescent plasma being there, that is another mode of treatment that we are trying to see if it produces any results or not. Can you please enumerate on why WHO declined the use of hydroxychloroquine? Like I already said before, hydroxychloroquine has not really shown any effectiveness in patients who are taking it versus patients who have not taken it in fighting COVID-19. In fact, initially they were thinking that having a component of anti-inflammation, maybe they can help people in decreasing the span of the disease, but it hasn't shown any difference so far. People who have not taken COVID-19 are suffering for 14 to 21 days. People who have taken the hydroxychloroquine for COVID-19 are suffering for the exact same amount of time. And again, I am emphasizing that hydroxychloroquine has been shown to cause a lot of electrical nodal problems in the heart issues in the patients who have pacemakers or in the patients who have predisposed cardiac history. because hydroxychloroquine can cause QTC prolongation. It's a part of the heart rhythm that it interferes with, and it predisposes the person to cardiac arrest. So that those were some of the reasons which I would say that can be the basis why WHO have declined it. We have heard that the hantavirus is more dangerous than COVID-19. How is it spreading? Like, why will it be spreading in the same rate as COVID-19, or is it less contagious? Okay, so I would be very honest with you. Who is this Nico? I have not had any experience with hantavirus, and I do not know of any patients that I have seen who has the hantavirus as of now. But I don't know. Although there has been like I don't think there is any licensed vaccine against hantavirus infection that can be widely used. And honestly, despite inactivated virus hantavirus vaccines, which are being licensed for human use in China and Korea, I don't think US or Europe has even thought about approving this vaccine so far. And I don't know, I cannot say for a fact that I can compare a person who has had this hantavirus infection versus a person who is COVID-19 because I have not personally seen, but I don't think that vaccination will be easy for hantavirus legally so far. Let's see. What do you think about herd immunity? Morbidity due to COVID-19 is significantly low till now. In such a circumstance, is it possible to take herd immunity as national policy? It could act as a selection pressure on human race and choose the fit individuals too. Whoa, yes. Yeah, herd immunity is something which we have talked about a lot in our, it's funny because all of us who are also resident physicians, we are also equally very interested about herd immunity, and we are like, why isn't herd immunity used as a mechanism right now, which we are not thinking about yet. But before even we think about herd immunity, first of all, it's very important to know that whether it would be a good choice. Yes, the number of patients who are going into severity from COVID-19 is decreasing, but that number is not at all anywhere near where we can be risky with this virus yet. I agree. Herd immunity may be the answer because that's how we can protect populations against being affected by this virus. But I will not actually let me quote a little bit of something which my attending sent us today. Due to, let me see if I can find it out for you guys because it's very interesting. Johns Hopkins is actually one of the places who are thinking about the herd immunity. We have listened with concern to voices suggesting that herd immunity may soon slow the spread of COVID-19. However, he is an ID doctor. He said that as an infectious disease epidemiologist, we wish to state clearly that herd immunity against COVID-19 will not be achieved at the population level in 2020, barring a public health catastrophe. I know it's something that we are very interested to know, but we have to look at it in terms of reality versus just reading. In reality, we are still not comfortable unless we go into August, September with our ICUs having no admission whatsoever for COVID-19. We cannot say we are there yet. Have you seen any case of reinfection after recovery? Yes, I did. And I shared with everybody that I did see cases of reinfection. Well, in those cases, I would say though that I have not seen someone who has recovered and then got reinfected and gone to the ICU. But I have definitely seen reinfection. In fact, I was talking about one of my pregnant patients who was initially positive for COVID, along with her husband, and they were way past the even 21-day period after they contracted the disease. They were healthy, okay, But once she delivered her baby, she was retested for COVID-19, given that she started spiking fevers. And usually, at that time, it was not known whether it was due to any infection pertaining to the delivery of the baby or is it any COVID-19 related fever. So she started spiking fevers up to 102, 103, and even her little baby contracted fevers. And I was looking at taking care of the baby actually, and baby had a max temperature of 101.8. So at that particular time, we retested the mom and the baby, and mom was again COVID positive. So how do we know that she got reinfected and she didn't recover? Well, the only reason I can say that that line was still there was because after she quarantined herself for 21 days, given the fact that she's going to go into a um, OB unit, she was retested, and at that time she was negative. But how did she contract it again? Did her husband infect her? How did this happen? How did the baby get it? When exactly did it happen? We don't know. But I have definitely seen the reinfection. But she was okay. Like after we actually sent them home with proper precautions. Baby was completely fine. She had fever for a day, so we monitored her vitals and everything. Respiratory saturations, like all the saturation of oxygen was fine. Weight was improving. She was eating okay. Her weight loss was not too bad. So they were sent home with precautions, and it has not been 14 days yet, so I don't know if the second result has come back. But I did see it, that they got reinfected. On a mask, taking multivitamin is required to fight, well, anything and everything that makes your immune system stronger. Take it. Multivitamins, yes, for sure. I tell my patients who are above the age of 60 and they have chronic comorbidities, taking a multivitamin gummy or tablet, or just making sure your fruits that you are having fruits and vegetables which are rich in multivitamin can only help you and not harm you. So yes, it builds your immune system, makes it stronger. So I would say, why not? You should take it. Uh, what could be the possible long-term health issues? You know what, guys? I can go on and on and on, but I also know that it's. I don't know how tired are you guys. I'm okay, but again, I have to go to work tomorrow. It's almost 1:30 a.m. here, so I'm just gonna try. In fact, Dr. Kaur, you probably have to help me a little bit to answer a few more questions today, and maybe I can get back later.
Yeah, Nandini, there is a
So
question on
select some of the
remdesivir.
questions for me that I can answer right now.
Yeah, there is a question on remdesivir. Can you put some light on that? That whether how effective is this one, and if other than this we
Yeah,
can have some
is
other
there one? Okay,
antiviral.
let's
Remdesivir is
see.
there's a question
This
from Shomita Height.
the antiviral drug.
Yeah, okay. Yeah. Okay, hi, Shumita. Thank you for the question. And yes, remdesivir is basically what it does, so far as I know, is our very famous SARS-CoV-2. It's an RNA virus, and RNA-dependent polymerase is usually used for its replication. And remdesivir goes and binds to this polymerase and prevents its replication. In fact, I don't know if you guys know about it, remdesivir was actually used in treatment of Ebola. Uh, it is being used. I will be wrong to say that it's not used. It's used in what we call compassionate care in some of our COVID patients. So, what does compassionate care mean? We have not seen any difference in the mortality rate with remdesivir, but it has shown in some of these patients to have brought down the number of days that they are suffering severely. Like, suppose if they are needing or requiring oxygen, it has shown in some cases, again, I will not be able to divulge the exact data, and that's why the remdesivir trials are like right now a very hot topic of discussion. But it definitely is something. And I was talking to one of my friends, and even he said that right now our hope is vaccine and remdesivir. But yes, it's being used, but I cannot comment on the efficacy because we have also seen patients who did not need it. They went home, they were fine, and some people who needed it who did not show much effects. So everything is like hanging out there, and we just need everything to come together. And unfortunately, that takes years and years. Forget about months. We need something like immediate. We need something which would make sure that we have our answer in 3 4 months. And that's why let's keep our hopes held high and we can see how things go in the next few months. Anything else?
which is I think
There is another
we should
question.
wrap up, because
Reinfection more dreadful than the previous weaker, as there are antibodies
Um,
in the body. So that's
yeah,
one question
so
on
I
reinfection. Yeah.
Yeah, so I think I was talking about this reinfection right now that I did see the reinfection in my pregnant patient, but so she still had fever. She did not seem to have anything severe. She was otherwise fine, eating okay, everything, but she was spiking fevers, the same that she was having in her first time when she got infected with COVID-19. So it's definitely, I cannot say that it is weaker because they have had the antibodies. Because if that would have been the case, then she would have had fever for just a day or two. But she continued spiking fever for 3 to 4 days, the same amount of time that she had the first time. But now we are seeing that for my other friend who was a healthcare worker, and she tested positive for the IgM antibody, meaning like she is still in an infectious stage. She's completely asymptomatic. Like there's nothing. So even when she was infected with COVID-19, she just had a dry cough and she was coughing. She said like she wasn't able to complete her sentences and she was coughing so much. And right now, she's still assumed to be COVID positive because of the retest that they did, but she is asymptomatic. So definitely it might be much weaker in her. So it depends. It's like a case by case study, case scenario versus case scenario. What happens to me, how I fight an infection may not be the same as how you fight the infection. So it's still the reason why we still can't say one answer to this as of now is because there has not been enough number of people who have had weaker infection, weaker reinfection, or there has not been enough number of people who had severe reinfection. So that's why it's just a question of immunity at this point. My little advice to all of you out there would be enhance your immune system. People who are more prone to this disease are people who have immunocompromised states like diabetes, people who are smokers. I continuously tell it to people who I know who are smokers that what happens in this COVID cases is the cilia in your body is already destroyed because of chronic smoking. So people who has been smoking for a prolonged period of time, their chances of contracting COVID might be later that they don't contract immediately because the cilia in which this virus stick to are not there, they're destroyed, so it takes a longer time. But if they are infected, their lungs will be destroyed at a faster rate compared to a person who does not smoke. So in those people, I can only imagine that the reinfection will be severe, probably. So it will be at this point just making sure that everybody is taking their own bit of vitamin C, cleaning their hands, taking precautions of making sure that all the stuff that they are buying from outside are clean, regardless of COVID-19 or not, making sure that everything is clean. Don't wear your shoes inside. If you know of a person who has come into contact with a COVID positive person or somebody who is a patient right now, please be affectionate and sympathetic and empathetic to them because they are the people who should be taken care of, but you should take your precautions. to visit them. And right now, if you are surrounded by elderly people, by people who have multiple comorbidities, try to limit your exposure to them. If you have to go out to get stuff, to go for work, make sure that you come home, clean yourselves, wash your clothes often, make sure the stuff that is there around the house get cleaned often. For now, for the next few months, grab a pair of gloves and one mask to go to your groceries regularly. That would be my piece of advice.
Okay, so uh, we are almost at the end of this lecture session. I would request Professor Bhattacharya to comment on it, and then we can take a couple of questions if anybody wish to ask anything more. So, Matridi, please.
Yeah. I, we are very much thankful to Nandini because she had given us a elaborate description about her work experience as well as a guidance for us, and really it was a good advisory so that we can uh, go ahead in the future days. I appreciate Nandini that she's not only a doctor, she's a courageous practitioner, medical practitioner, but along with that, she is highly research minded and she has analyzed the questions with always with the technology, with the molecular biology sense and with the biochemistry and also the recombinant DNA technology. So this is a very important thing which we always emphasize from our JBNSTS platform, that the doctors, engineers, whoever it may be, we always research minded. And Nandini has indicated us that, and I know that she will go a longer distances, she will go a longer path to achieve her goal because definitely she will be a very good medical scientist in future days. And as of now, we are also very much proud that our research, that our JBNST scholars have also interacted with her. And I think it is a very fruitful discussion. And I know that it's very late for Nandini because it is almost 1:30. It's almost 1:30 night. Is it, Nandini?
Yeah, it is. It is, but it's okay because I enjoyed and I loved talking because I know that when I was in their position, my mind, even now, we are so curious about finding out more and more. So thank you, Dr. Bhattacharya, Dr. Kaur.
I think we have also snatched your sleeping time. So it's very late.
She need to
It's
attend the
okay.
patient tomorrow morning in the 6 a.m. She said already.
Oh, oh. So, Opjit, I think we should wrap up now as of
Yeah,
now.
yeah. We should. So once again, big round of applause to Dr. Nandini Chattopadhyay for such elaborating and nice lecture, and we should have to have you in future as well.
Exactly.
Sure, I would love to. And I wish for you all a very, very bright future. And let's keep these questions coming because these minds of today are going to be the actual researchers of tomorrow. So, and I hope, like Dr. Bhattacharya said, that I want to do research in the future again after having a background of medicine. I want to teach in the future too. So I'm pretty sure that our paths are going to cross in the future. And I hope to bring in some good news, positive news next time. But I appreciate all the efforts, all the questions. They were really, really good and strong. And I appreciate Dr. Bhattacharya, Moitri Kakia for letting me be a speaker and share my experiences. Thank you so much, everyone.
Thank you so much.
Sure. Thank you, Nandini. Many, many thanks.
So we would like to conclude the
You're
meeting,
Yes,
right? Yeah, Matridi?
yes. Okay, well, we conclude. And many thanks, Nandini, and our congratulations for your journey ahead.
Thank you.
Thank you.
Thank you.
Bye
Your
bye.
blessings are Thank you. Bye.
Bye. Bye.
Oh,